Thank you. First off, welcome to Medicine Grand Rounds on this first Tuesday in February. I apologize that everybody is going through the process of going through the waiting room, but I also apologize for the bit of Zoom bombing we had last week, which is why we have enabled the waiting room. And so I appreciate your patience. Today, however, I am delighted to introduce my good friend and colleague, Dr. Kimberly Workowski. Dr. Workowski is a professor of medicine in infectious disease. She has been here for 32 years and is sort of one of our senior faculty in ID and serves as a mentor for many. She also serves as a medical consultant to the CDC and coordinates the development of the CDC STI treatment guidelines, which is the national and international standard for the management of sexually transmitted infections. And as such, Dr. Workowski really is one of the handful of national experts on sexually transmitted infections and is a true resource and treasure for us here at Emory. She also serves on the National Guidelines Committee, including the HIV Prevention and Opportunistic Infection Guidelines, serving as the Syphilis Chair. It's a great title, the Syphilis Chair. The IDSA and AASLD Hepatitis C Guidelines Panel, the ACIP Mpox Vaccine Working Group, and as a member of the forthcoming recommendations on the CDC doxycycline post-exposure prophylaxis for bacterial sexually transmitted infections. She provides technical guidance on the Scientific Advisory Council for the ID Clinical Research Consortium Sexually Transmitted Infection Working Group, providing technical assistance on novel clinical trial design, translational and behavioral research, pathogenesis, and the vaccine development program. And she has many active studies ongoing, including investigating novel therapeutics for STIs and HIV in patients co-infected with HIV, syphilis pathogenesis, HIV cure research, and STI prevention interventional trials. Dr. Workowski is also a beloved clinician. Her patients utterly adore her and is on speed dial for all of us for advice in all kinds of different venues. I will say that this is incredibly timely given the news about syphilis that came out just in the past week about the record levels of syphilis. And I think this this talk will really bring us into this the current era and think about how we should think about new developments in STIs. So Dr. Workowski, my friend Kim, take it away.
Thank you so much, Wendy, and thank you for the opportunity to talk to you guys. So what I'm going to do is quickly go through my favorite topic. And unfortunately, I can't talk about all STIs, but I will just spend my time talking about the bacterial STIs. We'll talk about some prevention strategies. I'm going to weave in there what we're doing at Emory, which is incredibly exciting in some of these areas, and then talk about some of the challenges that we have, both on the management and antimicrobial resistance. So my disclosures, the studies I'm going to be talking about are funded through the NIH. And as Wendy mentioned, I've been at CDC for a number of years, serving as a medical consultant. So first, let's just get started on the picture globally. And this is kind of an imprecise number because we don't have adequate surveillance in all areas of the globe. But this gives you
slides if you're showing them.
You can't see them?
Correct.
I just had them up with Kimberly. Okay. Let's try again. She told me that she saw them.
Now this is looking more promising.
Okay.
And yeah.
How about now?
Perfect.
Okay. So this is just a map of the globe showing what we see globally, 374 million, which is an underestimate of what we see. But really what I'm going to talk about today is what's going on here in the United States. And yes, this is a timely talk. The CDC just announced their 2022 surveillance. Yes, that is correct. They're still working on 2023. And all the problems that happened with the pandemic have, we're taking the surveillance, what we have. Sometimes things weren't reported, of course, during the pandemic. But what this just continues to show us is for the past 8 years, that has been a trajectory upward of all STIs. Now, we didn't see as much in chlamydia. Some of that may be to testing, but some global maps that are really indicative of how important this is in all the STIs. So what you may not be aware of, because this happened in the middle of the pandemic, is there was a national strategic plan that was kind of announced about STIs. And it gave a kind of roadmap for us to help going forward with the dramatic increases that we've seen. Now, this particular strategic plan only dealt with chlamydia, gonorrhea, syphilis, and HPV, but it gave us a roadmap with measurable objectives to see how we're doing along the way. And we'll get back to this, why this is important when we talk about what's happening with syphilis. So before I get started, I really want to say that I'm really going to spend the majority of the time on syphilis. Number one, because it is fascinating on many levels, both in the way it presents, its pathogenesis, and the epidemic that we have that is just unbelievable. And then I'm going to touch a little bit on chlamydia and gonorrhea and maybe a little bit of Mycoplasma genitalium at the end. So what have been our challenges? Number one is that we really have a syndemic. So it's not kind of like the strategic plans, which I list up here, that were released serial by the government. It's basically, we have STIs occurring with HIV, viral hepatitis, and substance use disorder. So that's a problem in terms of thinking about the folks that are at risk for these different infections and knowing that there's jumping back and forth between these different areas. It kind of gives me another indication things aren't siloed. They're basically all existing together. The WHO, though, has produced a report that basically talks about this syndemic in really nice detail. Also, most of the STIs are either asymptomatic or have atypical presentations. And yes, I will show you lots of graphic pictures as part of this presentation. They travel together. So there's also concurrent infection, and then there's antimicrobial resistance, especially in gonorrhea and Mycoplasma genitalium. And we can't do an ID talk without talking about the pandemic and what happened because of the pandemic. And a lot of our public health infrastructure was reduced. The infrastructure was diverted, and then there were shortages, both in manpower, in supplies, and also in antimicrobials. And then we're also limited is that we don't have good point of care diagnostics. I list down there at the last bullet there, a really interesting article by Ellen Kirsch at the CDC that talks about what we do have. And I'll come back to the second assay, which is a point of care nucleic acid amplification test that we're actually using now in a clinical trial. That's very exciting. So what can we do with all these things what the tools do we have in our toolbox for prevention? Number one, the first thing is we have to do a health assessment, a sexual health assessment, to routinize talking about sexual health, the same thing we do when we ask patients about tobacco, depression, intimate partner violence, substance abuse. We talk about in our field the 5 Ps: partners, practices, protection, past history, and pregnancy. It kind of rolls off your tongue, but those are the things that we want to kind of talk about. We need to do both a behavioral assessment as well as a biologic assessment. And the biologic assessment is because most STDs are asymptomatic. So we have some guidance to help us. One is the U.S. Public Service Task Force, and I list for you all the different screening guidelines that are available through the U.S. Service Task Force. Also, the CDC treatment guidelines, which actually started in the 1970s as kind of a treatise on how to treat gonorrhea, and has really evolved over time to be a very comprehensive document. What you may not be aware of is there's 2 documents. One is the management and treatment, and the other is a document we put out in 21 that talks about what services, equipment, antimicrobials and things you need, whether you're doing basic care or whether you're a specialized clinic, to help you set up what you need to assess STIs. We also have vaccinations as tools: HPV, hepatitis A and B, and monkeypox vaccine. the importance of partners. Whenever we talk about STIs, we need to think about how the partner is going to be evaluated in treatment and treated. And then we think about what are the prevention methods we have that are available. We have condoms, we have HIV PrEP, we've got HIV post-exposure prophylaxis, and then I'm going to talk a little bit about all the rage that people are talking about now is Doxy-PEP, and thinking deeply about what we're doing, what the data shows, and how we have to carefully use this important tool. So I'm going to jump into the data on Doxy-PEP, and we're going to start with a trial that was done, kind of a sub-trial that was done in a Doxy-PEP study, and basically, a HIV PrEP study, where patients were enrolled and compared to either daily PrEP or on-demand PrEP. And at a sub-study, in this Ypres study that was done in France, randomized some people to get doxycycline 200 milligrams within 24 to 72 hours after sex. And the other group was no PEP. And what's important here is there was a limit on the use of antibiotics, right? There was less than 6 pills administered per week, and most people used about 7 pills per month. And then patients came in periodically and got STI screens. And what this shows was a dramatic reduction in chlamydia and syphilis rates. This initial trial did not show a decrease in chlamydia, in gonorrhea, probably because the prevalence of tetracycline resistance was so high in gonorrhea. But then when they did a deep dive to look at who actually got these STIs as part of this trial, there was a subset of very highly sexually active individuals. So only 39% of the participants accounted for the majority of all STIs. Then after this study, there was a study called Doxy-PEP that was done in the United States, in Seattle and San Francisco. And it looked at 2 cohorts of men who have sex with men and transgender women. And those individuals that did not have HIV but were on HIV PrEP, and those individuals that were living with HIV all had significant reductions in gonorrhea, chlamydia, and syphilis. However, the numbers for syphilis here are really small in this study. And there was quite a dramatic reduction. And it's the same thing, 200 milligrams post sexual contact within 72 hours of contact. The third study that is ongoing is a study called Doxy-VAC, which is again looking at men who have sex with men that are on HIV PrEP and randomizing them to 4 different arms, either a doxycycline or a Bexsero vaccine. We'll get to Bexsero vaccine, which is a group B meningococcal vaccine that has shown some activity against gonorrhea. And I'm showing you some of the data that was presented at CROI a couple of years ago, which is our national HIV meetings. And in this study, they again showed a decrease in chlamydia, syphilis, and also gonorrhea, which I don't have mentioned here on this slide. But also there was a decrease in the incidence of gonorrhea. We'll talk a little bit more about this when we talk about gonorrhea. But you have now 3 trials which have shown efficacy by using this intervention in MSM and transgender women. However, there was also a recent article that was done in Kenya that looked at this intervention in women, and there was no efficacy in women. And there was a nice editorial by Jeannie Marazzo talking about what this showed, similar to a trial that she had performed using HIV PrEP that called the VOICE trial, that wasn't effective in preventing HIV, and talked about the differences are there differences in terms of the way this drug was used? We think so. We think it may be to do something with adherence. But because of these studies, the CDC has some preliminary guidance, and other guidance, the formal guidance is forthcoming. Hopefully by April, it should be published in the MMWR. But when we're thinking about this as intervention and thinking of ID doctors thinking about this, when we're supposed to be antimicrobial stewards, the issue is, how do we implement this in practice? Do we open it up for everybody to use it, or do we have more restrictive criteria? Are we thinking more about an individual impact or a population-based impact? And what about other bacteria, commensals that live in our mouth, our rectum, our urogenital tract? What about Staph aureus? So those are the things that are kind of ongoing that we're thinking about. So, and what I list on the right-hand side of the slide is all the editorials and the papers that are coming out now about, wait a minute, this is, let's think clearly about what we're doing, because there is demonstration that you can have resistance in other pathogens through the sharing of DNA, thinking about where these organisms live. And so there's as if you're thinking about implementing this in your practice, my personal opinion is that it needs to be done through shared decision making, not through all comers do the same thing. You give all these pills and with all these refills, you have to be very thoughtful, in my view, of thinking about how you're going to use this intervention, this important intervention. So I list this here on these slides for you guys to think about, because there are implications of widespread antimicrobial use. And so I have very long-standing and difficult discussions with patients about the pros and cons of this approach. But this is an important approach in terms of our toolbox. So let's jump from prevention to syphilis and show you a little bit of the epi and tell you what's going on. What I list here is a graph from CDC going from 1990 to current. And if those of you remember in the early 90s when there was this jump in syphilis rates, this was the crack cocaine epidemic. And then we had this explosion of syphilis, mostly occurring in men who have sex with men, that occurred over the last 20 years. However, what you notice here is that there's been this dramatic increase in the last 10 years in female syphilis, which again corresponds to what we're seeing in congenital syphilis, which is, in my view, a public health emergency. And if you follow this along, you can follow this by this kind of ribbon plot, where you can see the difference in rates, and you can really see the dramatic increase in women. This is men who have sex with women, and this is men who have sex with an unknown partner. You can see that there's been a kind of a dramatic shift from, into the heterosexual population. And then the other things we think about is the bridging, the people that bridge between heterosexual population and the MSM population. So they bridge between two populations. And so that is very concerning kind of going forward. I think this visual says it all. I don't even need to say anything. 2013 to 2022, this is what happened with syphilis over the past 10 years. So it's in pretty much every state. It's gone really crazy. The other thing that's associated with this, if you look at the most current report in syphilis and behavior, the difference in behaviors in women, men who have sex with men, and this is up to 40% of syphilis is occurring of women who have sex while intoxicated, 20% sex with anonymous partners. In men who have sex with men, it's more sex with anonymous partners and less sex when intoxicated. But as I mentioned before, this is a syndemic, and what we're seeing, instead of the cocaine that we saw, decades ago, we're now seeing it associated with methamphetamine. This is congenital syphilis. And again, this is quite disturbing. You see the difference in the last 10 years with the increase kind of blanketing the United States. Oh, and just an aside, Georgia, we're number 6 for the highest congenital syphilis rates in the country. This other table that CDC just came out is very interesting, a way to look at the ethnic disparities. And the left-hand side here, you say this is the percent of live births in 2022. And this is the percent of congenital syphilis cases. So what you can see is the difference in the disparities looking at live birth versus congenital syphilis. And the highest rates are actually in Native Americans and Pacific Islanders, where there's been dramatic increases in the amount of syphilis we've seen. One of the problems with syphilis is it's so complicated. And that's why we continue to get calls all the time about it. It's not straightforward. It constantly baffles us. It's humbling. And the part of the problem here, and this is a nice kind of depiction in this nice article by Khalil Ghanem a couple years ago in the New England Journal, is that it can jump. It's not linear between stages. You can go to primary to early latent and then back to secondary and all around and repeat the cycle. We know about 30 to 40% of people get CNS invasion. Most people are asymptomatic and they kind of clear it from their CSF. But you can have both early neurosyphilis, late neurosyphilis, and it's very challenging. And whatever field you're in, you can have, you can see syphilis. This is Daniel Garcia and Russell Kemker in our group saw this patient that was a patient from that had syphilis like 20 years ago, was appropriately treated and came back 20 years later and had this huge ascending aortic aneurysm. This is an example of a patient that had a meningovascular stroke. So it continues to humble us, and these syphilis can have incredible complications and consequences. This is one of my favorite slides because it lists pretty much all these patients that I've seen personally recently, and it's quite humbling. The way that these ulcers present on a lip, on a penis, on a vulva. This was a poor woman who was sexually assaulted, and this was her chancre. This is a nose. This is a tongue. We have condyloma lata here. We have a patient that presented with came in for a routine exam and found this was the only manifestation of syphilis, were these mucus patches and ulcerated tonsils. So again, it is incredibly humbling, and it can present in many different ways. We recently published a review article on congenital syphilis, and it just happened that it just came out right around the time the surveillance report did, and trying to really highlight the horrible manifestations you can have with congenital syphilis. The snuffles, the buttock erosions, the desquamative rashes. This is a huge placenta and this maculopapular rash. And so this is a true public health emergency. So what can we glean? What are factors that are associated with syphilis? One of the things I talked about before is that STIs travel together. And so if you have somebody that presents with one thing, you need to test for all things. And so concurrent chlamydia, gonorrhea, there's a educational disparity. I mentioned disparities in terms of race and ethnicity. And again, if patients aren't screened or they prevent to prenatal care late in life or late in their pregnancy, excuse me, there's an increased risk of having congenital syphilis. Then we have the debacle that all these individual states have different screening laws for syphilis. So the recommendations are to be screened at least the first prenatal visit. And if there's risk factors, or if you live in a community with a high prevalence of syphilis, you screen at 28 weeks and then again delivery. And again, look at these differences here in all these states. 8 states don't even have screening laws. And a lot of this has to do through through their state mandates. And so it's really complicated. The other thing I wanted to mention is that this was a great MMWR that was done a couple of years ago that looked at all the congenital syphilis cases in 2022. To me, this is horrifying. No timely or undocumented test, 36%. Inadequate treatment, almost 40%. No documented treatment, 11%. And then you can still have congenital syphilis despite being treated per guidelines. It can happen. We had 130 cases in 2022. So we have to think out of the box, right? We have to get out of our traditional settings and think about mobile vans. How do we reach patients, partners? Thinking about the syndemic that we have. We do have point of care tests. They're not the best, but they're underutilized. They test treponemal antibodies, but they are available. We've got to meet people where they are in their communities. Recently, HHS announced huge actions to slow the syphilis epidemic, which has been going on for, as I mentioned, for a very long time. There's a task force that meets weekly. Priority jurisdictions, there you see Georgia right here, with priority populations. So this is getting people to talk about what we need to do across organizations, getting out in the community, thinking about bringing our tools into the community. So it is a real epidemic, and what's happening in congenital syphilis is just absolutely heartbreaking. So what tools do we have? The problem is we're using some tools that were developed in the 40s. And there hasn't been much innovation in terms of diagnostics. So WHO came out with where we are currently. Later this week on Thursday, CDC will be releasing syphilis test guidelines that have to do with the laboratories and all the tools we have available. So one of the main problems is we have no point of care test for syphilis. We don't have most places don't have dark field. We don't have DFA anymore in the United States. Immunohistochemistry is only for tissue. And there is some data, which I'll show you on the next slide, about using nucleic acid amplification tests, which are really exciting, but they're not commercially available. They're only used for research. So these were two studies, one that was done in Australia and one that we did here at Emory in collaboration with our partners at UAB, which basically looked just doing blind swabs of the throat and the rectum in patients that presented with primary, secondary, and early latent syphilis, whether they had symptoms at that location or not. And what is really remarkable in primary syphilis, 49%, secondary 69% had that we could find syphilis despite absence of lesions. We found kind of something similar here that in a paper that we published recently. But what was so remarkable was what we found in early latent. That's with no signs or symptoms. 62% of the time we were able to find the organisms in the throat or the rectum. And it really did depend on stage of syphilis and organism burden. So thinking that this may be something we could use going forward, we just need a little bit more study. And then we have serology, which again is decades old, has problems. You need two tests. Either you can start with a non-treponemal test or start with a treponemal test. Each kind of version you use of this algorithm has problems. I mentioned here, even when somebody comes in with a primary chancre, that you can miss at 40% of the time. So again, my main point of this slide is what's here in red. Never interpret a serology in the absence of a clinical history and an exam. You can't diagnose syphilis by a blood test. It has to be a combination. What about neurosyphilis? Well, that's even more complicated because our tools, again, we don't have good tools. Neurosyphilis is complicated. This is a really good review article for anybody that's interested that was just published in Clinical Infectious Diseases. But I put down here kind of a smattering of what our sensitivity is for these tests. They're not good. And so we have a real problem in terms of making a diagnosis of neurosyphilis. And that's why Wendy said pretty much the ID docs are on speed dial when people have questions about these tests, because it's complicated, the disease humbles us, and it's really challenging sometimes. So one of the things we're doing here at Emory to try to help with some of this is that we have partnered with University of North Carolina and 2 international partners to develop a biorepository of specimens for patients with syphilis. And so we're actually collecting specimens from many different sites. And hopefully with these tools that NIH can use we can use for developers to develop new tests and things that we can learn about syphilis as we follow people 6 months after the infection. The other thing that I've been working on with colleagues at CDC is looking at differences in strains, differences that cause ocular syphilis, neurosyphilis, macrolide resistance. And what we've been able to do, which is really interesting, is directly take the organism from lesions and rashes and use those to inject rabbits to start a rabbit model of things that we obtain, specimens that we obtain from the clinic. And what this is going to help us with eventually, hopefully, is vaccine development. So it's a really fun kind of project, but it's really interesting to see that we can do whole genome sequencing on this and then take this into the rabbit model. So let's go quickly to treatment and tell you what's an update for treatment. So one of the issues in syphilis treatment has been we've had one treatment available, and that's benzathine penicillin. And there's been some questions over the years about whether, especially in people with HIV and advanced HIV, whether we needed a single or multiple injections. And there's been a lot written about it in the literature. We finally did a definitive trial with 10 clinical sites around the country. The results were published, were presented at ID Week, and we're working on the publication now. But basically what that showed was that 3 shots did not perform better than 1 shot, even in patients with HIV. So this is kind of going to be the definitive trial that shows that we only need to give 1 shot of benzathine for early syphilis. The other interesting thing as part of this trial, there was very frequent co-infection. We screened over 800 patients for this trial, and look at the numbers of co-infection that we had. So again, reminding us that we need to look for chlamydia and gonorrhea at the sites that patients were penetrated. What about alternatives? We know Doxy works. We have limited data, though, that's available in the literature, actually. There's an RCT that's being done in France. We know ceftriaxone works. And there was a study done looking at cefixime, a very interesting early pilot study that seemed to have some effect. And then linezolid was just shown in Lancet Microbe, a 5-day trial of linezolid in syphilis, but it didn't work. Next week, I'm going to be going to NIH. They're having a whole workshop for 2 days on alternative therapies. I'm on the neurosyphilis alternative treatment kind of work group. And what we're doing is looking at potential drugs, thinking about what's available, what kind of data we have on CNS penetration, and making some recommendations to NIH. There's also a trial that's being proposed at present using doxycycline versus IV penicillin that we're working through this part of this work group. So very exciting, thinking about what the possibilities are. What about for syphilis during pregnancy? Again, we have to think about which antimicrobials can cross into the placenta and get to the baby. There's some early stuff that amoxicillin may work, but again, we'd have to use very high dose. It's 3 times a day. Other cephalosporins are being explored, but some things don't penetrate well. In particular, macrolides don't penetrate well in terms of getting to the fetus. So that's my quick run through syphilis. Now I'm going to quickly show you what else is really exciting that's happening with these other pathogens. First, I'm going to start with urethritis. And These are the organisms that cause the most common cause of urethritis: gonorrhea, Mycoplasma, genitalium, chlamydia, and Trichomonas vaginalis, but only in heterosexual men. One thing I just have to mention here, which is one of my pet peeves, is these multiplex diagnostics that are being done that are not FDA cleared, that people are looking for Urethritis, Mycoplasma hominis. And I want to show you, the reason I'm showing you this poster that was presented at one of our recent meetings is because this, especially Urethritis and Mycoplasma hominis, can just be a colonizer. It's not always associated with urethritis. There's documentation in our literature that don't even look for it. Europeans say the same thing, but it continues to permeate all these multiplex PCRs that people are trying to develop. So next, I'm going to go to gonorrhea. You've seen these slides before. We had a lot of it. It's worse in the South. What I'm going to spend my time on with gonorrhea, though, is a couple of things that you need to know about besides it's causing urethritis, cervicitis, neonatal infections in babies, is disseminated gonorrhea. It occurs uncommonly, but it presents two ways: either a monoarticular septic arthritis or a tenosynovitis polyarthralgia skin lesion. I have up here this rash I saw with a fellow, I think in the last year. This patient came in and had a vesicular, very painful vesicular rash. I've never seen that with DGI. But again, on close inspection, this patient had elevated, had a lot of edema in their lower extremity and had vesicular lesions. And the important thing about this was this diagnosis was not thought about until the genitalia was examined and there was profuse discharge coming from the vagina. Most of the infections can have, may be asymptomatic at the mucosal sites, and there's also eculizumab has been associated with a increased risk of having disseminated gonorrhea. But what's also interesting here is there's been a change in the epidemiology of this infection. And before, when we saw it in young women associated with menses, we're now seeing it an increase in older age in men, and again with this syndemic occurring with illicit drug use. If you have a case, or if you know about a case, there's a place you can report to CDC. We want to know about it. And we're also, there's ongoing surveillance now that has shown in several places about this change in epidemiology, which is just fascinating. We're also seeing a kind of a resurgence in gonococcal endocarditis. And I bring this up because I'm aware of 3 cases at Emory in the past 12 to 24 months. And this is a very destructive endocarditis that can really cause problems. And I think I'm still very much bothered by this last bullet here, this woman that I took care of, and probably some of you took care of as well, who was a 17-year-old girl who came over, was transferred here to Emory, she had sexual relations for the first time. She developed gonorrhea, PID, trichomonas, gonorrhea. She blew out her aortic root, and had to go to surgery, was on ECMO, and then succumbed to this infection. And it really talks about how pathogenic this organism is. It's horrible. And look at these other patients, the way they presented. A brachial artery thrombus, myositis, again, aortic root abscess. So this is used to be really common back in the 30s and 40s. But to say that we've had 3 cases at Emory, we need to be aware of this, and it is just very destructive in terms of the aorta. The biggest problem we're having with gonorrhea is antimicrobial resistance. This organism is really wily. It's determined. It's really figured out how to develop resistance to multiple antibiotics over time. CDC has had this surveillance system in place since the 1980s. And this is kind of how we have our finger on the pulse of what's happening around the country and make antimicrobial recommendations. So I just call your attention to the tetracycline resistance here. We think it's now between 25 and 30% in the United States. And again, getting back to what we said about Doxy-PEP. You can use this data really cool ways. One of the ways we can do it is to separate out different populations and watch the rise of antimicrobial resistance through populations. So using this helps us and determine how to determine which dose we're using for antibiotics. So back in 2020, we made some updates to the treatment guidelines and recommended that we increase the dose of ceftriaxone and we don't use azithromycin. And that was because of the rise in azithromycin resistance that we saw. And so we thought long and hard about the impact on the microbiome using these two antimicrobials. So think about the messages that were said in this, and then think about now what we're doing with Doxy-PEP. So again, we still want to be antibiotic stewards. We want to use our drugs appropriately. And so we really had a lot of thought into going into what we did with the gonorrhea treatment recommendations based on antimicrobial stewardship. Then I want to next move to this really exciting advance. And this is something that up here at the top left happened in New Zealand. There was an outbreak of meningococcal B in New Zealand. And they did population level vaccination. What they noticed was there was a decrease in gonorrhea rates, which was just fascinating, right? Because we haven't been able to develop a gonorrhea vaccine in decades. And Ann Jers took that information and went to her animal model and showed that, yes, there is an effect in an animal model looking at mice, that we can affect gonorrhea in the animal model. And so what I list here on the right is all the clinical trials that are currently ongoing in the United States, comparing the Bexsero vaccine, meningococcal B vaccine, to a placebo, and seeing if we can see this benefit on a population basis, because most of the previous studies were all retrospective. So we're doing this study here at Emory. This is the study we're doing here. We have 3 sites at Emory. And I'm proud to say that we have the highest enrolling site in the United States. It was great teamwork, and our goal is 2,200 patients, and we're up to around almost 1,800 patients in this trial. So what are the mechanisms? I don't have really a lot of time to go into this. This was a poster that we had at the European ID meetings a couple of months ago. But basically, there's very close homology between the outer membrane proteins of meningococcal group B and gonorrhea. So it's really fascinating, more information to come. But I think going forward, we're thinking about, this as a potential prevention approach going forward if things hold out. Next, I want to show you a little bit about chlamydia. And we'll talk about what's kind of new and exciting for chlamydia is something else that we're doing here at Emory. So again, rates going up, similar to what I've shown you before with chlamydia. I want to, though, go back before we talk about what we're doing and go back very long time to some studies that I initially did with my mentor, Walter Stamm, at University of Washington, trying to understand whether or not we can actually eradicate chlamydia. And chlamydia's life cycle is really fascinating. It's got 2 different versions, an elementary body and a reticulate body. And one of the things when I was in my training that was pervading in the chlamydia field is whether we could really kill chlamydia because of this reticulate body. It can kind of remain dormant, stay there, and then reactivate later. So this was a study that I did very early in my training where we looked at college-age women, and we did a bunch of testing in their cervix, their urethra, and rectal swabs. We used both cell culture, and PCR was just starting at this point. And what we showed was that you can eradicate it. We had PCR and culture, and the woman that got that was positive here was a different strain from the one that they were originally infected with. And so I was very interested early in my training about whether we could truly kill this organism with doxycycline. And we originally designed the study to use azithromycin compared with doxy, but funny that the azithromycin wasn't cleared, FDA cleared, and the sponsor didn't want to do this head-to-head study. So we ended up doing it with doxy. And then we also did a number of work on looking at different strains of chlamydia, showing clinical differences in the way that they presented. And I show you these slides because these are slides of one of the serovars, LGV, that can produce all kinds of different presentations. This is proctitis. You may be familiar with bilateral buboes. This was a fascinating gentleman who presented with rectal bleeding and pain. This looks like a tumor and was biopsied by 3 different docs and was sent to me by one of the colorectal surgeons. And I said, it's either chlamydia or herpes, which can form pseudotumors. And it ended up being chlamydia, L2B, which we typed at CDC. And this is a patient, again, with LGV that presented with just a nodule here. And then this patient presented with an ulcer in his mouth, and LGV, there's only been 6 or so cases in the literature reported of oral pharyngeal LGV. So it can present as an ulcer as well. Then the other thing that's happened in the chlamydia world was our 2 treatments for chlamydia were azithromycin and doxycycline. What you can see, some of these older studies here showed us that the effectiveness, this was used for non-gonococcal urethritis, but the effectiveness of azithromycin waned over time. These are studies that were done in rectal infections and showed that azithromycin didn't do so good in rectal infections. So we started to say, you know, we're really concerned about using azithromycin in the rectum because it doesn't seem to work as well. And there was meta-analysis that showed that doxy looked better. So we needed RCTs, and then we got 3 RCTs. These 2, one was done in Australia, one was done by Julie Dombrowski at University of Washington, and then this was done in France in women, all showed with these dramatic differences that doxy was much more effective against azithromycin. And we got a lot of pushback on this because azithromycin is single dose therapy, but look at these stark differences in treatment efficacy that were replicated in all these studies. So again, that's where the recommendations came from in terms of the use of doxy over azithromycin. But what we really don't know is we don't know what's the minimum duration of therapy that you need to give. And in fact, there was a study that was done by David Taylor Robinson in England that showed just giving a single dose of minocycline worked. And then there's other studies that were done 15, 20 years ago that showed that imperfect adherence, these patients even did well. So we proposed this study to do a 3 versus 7 day treatment of doxycycline for the treatment of chlamydia. And we just started it here at Emory. And there'll be several domestic sites and international sites that are going to be doing this, comparing 3 versus 7 in urogenital infection in women and rectal infection in men who have sex with men. So I'm just going to end with Mycoplasma genitalium, and I'll just show you some really quick data. Why this is important is because it causes about 1/4 of urethritis in men. It causes cervicitis in women. We don't know much about its natural history. We wrote a paper years ago on there's no reason to do population-based screening at this point because some of the natural history is a little bit undefined. And where the indication for testing is really for people that had persistent symptoms after urethritis, to consider it in urethritis and pelvic inflammatory disease. But the main reason to mention it is because it's hard to treat. And we've had dramatic decrease in resistance to azithromycin over time. The only quinolone that works is moxifloxacin, and all the other quinolones don't work. There is a test for resistance, looking for both macrolide and quinolone resistance, but it's not commercially available in the US. The countries that have it have been able to use to do resistance-based testing to help them determine which antibiotic to use. We don't have that yet here in the US. So we have recommendations. If your testing is not available, that we have, it's basically 2 weeks of therapy, Doxy for 7 days, followed by Moxie. Once we get this test, we'll be able to shorten the course. And hopefully that's where we're heading to, that we'll be able to have resistance-guided therapy for some of our STIs. So that was a whirlwind with the bacterial pathogens. But what I was trying to get at and talk about is the importance of both a behavioral risk assessment and biologic assessment with doing screening, because most STIs are asymptomatic. Follow your guidelines for screening and timely treatment. There's variable clinical presentations and profound consequences, especially with syphilis, but also for gonorrhea and chlamydia, which can cause PID. I forgot to mention the problems also we're having with the antibiotic shortages with benzathine penicillin and people being creative. There are consequences when people don't finish their course of antimicrobials. There's currently a syndemic. We have to work together with our partners to optimize our biomedical approaches. And Doxy-PEP is an important in our toolkit, but it's not the end-all be-all. And we need to really think about what we're doing, who we're using this in, and not giving a prescription with 5 refills and just saying, go at it. What are the individual and population benefit of what we're doing? Think about the structural factors that are contributing to health inequity, because historically we've only thought about behaviors and organism. And then we need innovation. We need better diagnostics. We need more treatment, better prevention strategies. We need to go and meet people where they are in terms of care delivery. And we need to target our interventions to the infected populations. I thank you for your attention. I could not have do my work if it weren't for these all engaged individuals and many more, too many more to mention, all my CDC colleagues and all this brain trust of people that is so passionate about taking care of populations that at times can be marginalized. And I'm so proud to be associated with all of them and to be trying to make a difference in terms of our approaches to dealing with such a condition that's so stigmatizing, both individually and at the population level. So I appreciate your attention and be happy to take any questions.
Thank you so much, Kim. That was fantastic. And there's lots of people in the chat saying the same. Please feel free, anybody, to either raise your hand or put a question in the chat. And I see my boss, Dr. Stevens, is the first one with his hand up. David, you're on mute.
Hi, Kim. Great talk. Thank you very much. We really appreciate it. A great update. I'm still a little confused about where you stand or where the recommendations are on Doxy-PEP.
Okay, so you can understand the angst from an antimicrobial stewardship kind of. So I have individual angst and I have group angst. So that is why, and everybody's kind of got different opinions on it. So think about it this way. This intervention works in targeted populations. So how do you make the recommendations? Is it 1 STI a year? We have data in men men who have sex with men and transgender women, we have it doesn't work in women. There's not really a biologic reason why it doesn't work in women, except that maybe women aren't taking it after all episodes after sex. So the devil is in the details. It does work for chlamydia and syphilis. I'm a little bit concerned about gonorrhea, thinking about what our prevalence of tetracycline resistance is in the community, and thinking that how are we going to be monitoring this? So one of the things that makes us a little bit nervous is the liberalization of give it to anybody that wants it. To understand that we've got to be stewards, and we also have an important intervention. The other thing that bothers me is, and I put on the slide all the data in terms of the bystander effects of other bacteria, and the sharing of DNA between Enterobacteriaceae. So it's a very angsty decision. So again, I have my own personal feelings about it, in that I feel that I should be able to provide it to somebody through shared decision making, through me counseling them, and the patient understanding the implications that this is not for sharing, this is for your individual use. But I still have a bit of angst. I know that was long, but that's my angst.
No, that's very helpful. Thank you very much.
Kim, really just good sort of basic question about when to do MGen testing. So not testing initially for urethritis, wait until negative for GC or failed treatment, question mark. So like,
yeah, that's a great question. So again, we differ from our international colleagues about this, and there may be changes in our current guidelines. What this came about is because thinking about what we're dealing with antimicrobial resistance, we don't know the natural history. We know about maybe 30% of the time chlamydia can spontaneously resolve. We don't know about so much about MGent. And if we use it only, the difficulty is this. There are some diagnostic tools that are available where they put MGent with trichomonas. Okay, there's a company available that's doing that. They're using it more for screening. So if you have somebody that's asymptomatic and they come back with an MGent, or there are multiplex assays now that come back as part of a screening tool in pregnancy, what are you going to do with that person that's asymptomatic, that's pregnant? How are you going to manage that? Does that make sense? Versus somebody that comes in with florid symptoms. So I think, to me, it makes more sense as part of the urethritis. If somebody comes in with urethritis, if we had that kind of resistance assay that we could determine, should I give them a macrolide or the quinolone, right? How should I handle that? That's 2 weeks of antibiotics for this pathogen. So that's some of the angst and decision that we're trying to grapple with this organism. There's some other agents that are available overseas, not here in the United States, that people have access to. So it's a really difficult question, and we're going to have to grapple with it. But right now, the recommendations are, if your patient fails initially urethritis, the next round is to test them for MGen and TRIC if they're a man who has sex with women, because it really doesn't occur in men who have sex with men, trichomonas. And then that's where we would test.
Thank you. There's a couple other questions in the chat. Sadly, I think we are after the hour, and so I'm going to have to let them go. Sorry, BK and Carlos. Thank you so much, Kim. I was just saying to somebody else, the other thing this was an incredible tour de force, but the other thing that's wonderful to hear and a great role model is hearing somebody who is really excited about their work and talks about how fascinating it is. And I think, reminds us all of, what a privilege it is to be in medicine in whatever area you love. So thanks for communicating your passion and teaching us a whole lot.
Thank you. Have a great day, everyone.